Good morning everyone, and my talk is easily missed knee injuries on radiographs, CT and MRI correlation. So this is going to be continuation of what we have discussed since morning, that every modality has its limitation and combination of these is the way to go ahead. I would like to thank Dr. Patkar, Dr. Malini for all my radiology knowledge, and Dr. Kshitij sir and all the organizers for the wonderful conference. So basically, we are going to see how a normal approach to radiograph of knee is, and then 10 case scenario where we can easily miss findings on knee radiographs and why CT and MRI will be important in these cases. So as we all know, the importance of orthogonal radiographs, at least two views have to be there. One is AP view and the other is basically the lateral view, also known as the horizontal beam lateral view. So the basic rule continues, you have to get these two views in cases of traumatic insults and injuries whenever you are going to see knee as well. So basically you don't miss things if you have two orthogonal views. We'll see examples. And you can pick up some gross injuries, traumas, displaced fractures very easily. So these are few examples where everybody can pick up the abnormality. We can see the fractures, displaced fragments. Lateral views help in conditions like patella fractures, and you can go for specific views as well in certain conditions like patella fractures. Here again, big displacement and fracture fragments, so nothing great to diagnose these and nothing can be missed. But what are the cases where we easily miss knee injuries on radiographs? So let's see a few scenarios. So this is an example of a radiograph AP view and same patient's lateral view. So yes, when we'll go ahead and see the rest of the images, which will be MR, we can pick up the finding easily. But here you can see that on AP view, it's look more or less normal kind of. We go ahead and we see that there is a linear undisplaced fracture reaching up to the articular margins with a lot of marrow edema surrounding this on MR. So MR is quite sensitive to pick up the marrow changes, and we can easily pick up these undisplaced fractures on various MRI sequences. Next example. So here again we have the AP as well as the lateral radiographs. And if we see, there is definite soft tissue edema, some effusion, but no obvious abnormality with the alignment. And when we go ahead with the MR of this patient, we can see a lot of findings which are disproportionate to what the radiograph was showing. And definitely these are soft tissue findings, so we are not about to see that in a radiograph. So this was a case of complete thickness, tear of the anterior cruciate ligament. And we have the pattern of marrow contusions where we have marrow edema along the posterior aspect of the lateral tibial condyle. We have joint effusion, and additionally we can comment upon the cartilage condition in the patella where we can see a fissuring of the cartilage and rest of the soft tissue abnormalities. We can see the menisci, the associated meniscal tears, tear of the medial collateral ligaments, etc. So all these intricate soft tissue injuries can definitely be commented upon by the modalities like MRI rather than a radiograph. So radiograph definitely will play a role as a primary modality, but many things can be missed. So another example of ACL trauma and injury where you can see that radiograph look pretty normal. That patient is almost 29 years old with history of trauma. And on MR, we can see that there is ACL injury, marrow edema pattern of pivot shift pattern injury, and also grade 2 signal in the posterior horn of medial meniscus. Next case scenario where we see a radiograph, AP view, and a lateral view. I'm sure you might have noticed this breach posteriorly, but can be missed on anterior radiograph if you don't take the lateral projection. And MR makes things very clear for all of us that there is a tear and avulsion injury at the tibial attachment site of the posterior cruciate ligament. So various combinations of sagittal, axial, coronal planes, that is multiplanar approach, and various sequences like T1, FATSAT, STIR sequences, and T2 gives us a good idea of soft tissue injury, marrow changes, and all these osseous injuries as well on MR. So we can clearly see the avulsion site on the 3-plane MR images. So another example, similar findings here again, and we can see the CT reconstruction telling us about this fractured fragment. So CT has this wonderful capability of reconstruction, and patients who are getting in for surgeries, they give excellent idea for pre-surgical planning. So these are the examples of avulsion fractures, PCL. Coming next to these kinds of radiograph where the patient has pain, easily missed condition if we are not very careful, but on MR you cannot miss this. These are stress fractures, so linear areas of hyperintensities on fat sat images. They can be even down, not at the knee joint itself, and they can also be picked up on your CT scans. So here's another example. You see this linear, relatively dense area. You can definitely pick up this with experience, and it is the site of pain, but on MR you will definitely not miss this. So there is disproportionate marrow edema around this site, and this is stress fracture. Next situation, radiograph, relatively normal, but yes, retrospectively you can see that there is a differential sclerosis here on the medial side, and MR beautifully showing the subchondral insufficiency fracture. Associated findings like Baker cyst with associated partial rupture can be seen with MR. So these are the examples where you see that a lot of informations may be missed by simple radiographic approach. So subchondral insufficiency fracture. Next example, radiograph showing almost clear findings, and what we see here is a transient patellar dislocation pattern of marrow contusion. So you see that there is marrow contusion on the medial side of patella and lateral side of the femoral condyle. So we all know the mechanism of injury of a patellar dislocation, because of which this typical pattern of marrow contusion is found on MR, and because of which we can see that there is these kind of changes, and also we can comment upon the MPFL, medial patellofemoral ligament, and we can also comment upon various factors causing this instability on MR and CT both. So that is the advantage of this cross-sectional imaging, where you can comment upon the sulcal depth, the TTTG distance, and all of us know the importance of these measurements. So CT and MR in these cases, and also we can identify these small chondral fragments. As this was already discussed in detail, so physeal injuries are easily missed on radiographs, so Salter-Harris kind of fractures, but MR and CT can help both of these in pediatric, specifically pediatric injuries, so we should not miss doing these investigations. Next is these physeal bars. So also these are equally two injuries, and they can be missed on plain radiographs. They can be cause of growth arrest. So your CT and MR will be useful in picking up these arrest bars. Few last cases. All of us know that the soft tissue injury, muscle injury, which is associated with pain and secondary to trauma, can be missed on a radiograph. It will be completely normal, but the clinical features will be disproportionate. So something like low-grade sprain, something like muscle tear, all of these can be picked with soft tissue imaging modality, which is MR. And something like focal epiphyseal edema zone also can be picked with modalities like MR rather than plain radiograph. So to conclude, radiograph are definitely the primary modality of imaging in trauma. Orthogonal views are important, but it has its own sets of limitation, and we should take the advantage of CT, MR being multiplanar and come to a conclusion. So if clinical symptoms are disproportionate to the radiographs, please go ahead with CT and MR. So thank you for listening. You can take the questions.